All right, it's about 7 p.m., so I'm going to go ahead and get started. So hi, everyone. My name is Kelsey Shane. I'm the Executive Director at the Canadian Digestive Health Foundation, and I'd like to welcome you to this evening's webinar titled Mind-Gut Connections for Digestive Disorders. So just a few housekeeping items before we get started. If you do have any questions for the speakers, if you could please input them into the chat box at the bottom of your screen where it says Q&A. And if you have any specific questions for a specific speaker, then please just indicate their name before your question. The Q&A will take place at the end of the presentation, and we will get to as many questions as we can. And the recording will be available on CDHF.ca to review on a later date, so stay tuned for that. So without further ado, I'd love to welcome the speakers for this evening that we are very happy to have. First is Dr. Maitreyi Raman. She is a gastroenterologist and physician nutrition specialist, as well as associate professor at the University of Calgary, as well as director of LifeMD, which she'll be talking about a little bit later. And we also have Dr. Christopher Andrews, who is a gastroenterologist as well, clinical professor at the Division of Gastroenterology, as well at the University of Calgary. So welcome both of them to this webinar, and thank you very much for presenting for us this evening. And I will pass it off to Dr. Andrews.
It's a real pleasure to be here. Again, my name is Chris Andrews. I'm a gastroenterologist here at the University of Calgary. And it's a real pleasure to give this talk for the CDHF and to everybody who's present. So I'm going to talk first about the objectives here. I'm going to talk about the brain-gut connection, and that's the focus of this talk. And we're going to talk about how that plays into digestive disorders, and the ones that are probably most common where this plays a role is in inflammatory bowel disease, or IBD, and irritable bowel syndrome, or IBS. And we're going to talk about therapies or interventions to help with these disorders of brain-gut interaction. We're also going to talk a little bit about novel digital health interventions that might really be able to help with these types of digestive disorders. And so I give a lecture on this very subject actually to the medical students and here at the university. And it turns out that the GI course is actually the very first course that these students have. And so it's essentially like giving the talk to people who are right off the street and haven't had any medical training. And so that's perfect because that's the level I really like to keep it at. So the main thing I'm going to talk about is more the concepts are important, particularly if you're suffering with one of these digestive disorders. The details are not so important, but the idea is that we're trying to help understand what's going on between the brain and the gut. And the best way to start is to talk about pain and pain from the gut. How do you actually feel it? Well, to talk about that, we sort of have to talk about what are the machinery, what are the components of that system that make us feel. And so right at the level of the gut, we've got these sensory neuroreceptors. And what that means is just a little molecular machine that senses something. And often the most common one is a little sort of protein that senses stretching, for example. So these receptors are actually all over the place in the wall of the gut, in the muscle, and also in all the connective tissue that sort of holds the gut in place. There's also other neuroreceptors that sense chemicals and sense even bacteria, but they're throughout the gut. And it's really important for those sensors to be there because the gut needs to know what's going on in order to function. For example, it needs to know if there's food there, it needs to squeeze and start digesting the food. It needs to secrete the enzymes to help that digest. But if there's no food there, it also needs to know that so that it can sort of shut itself off. And that's all driven through these little neuroreceptors. And so it's wonderfully fascinating. It's wonderfully complex. And we don't understand everything about it, but we do know that it's a well-oiled machine to help your gut process food, digest things, absorb things, move things through, but also at the same time fight off invaders like bacteria. And so those sensory neuroreceptors are hooked up to the brain through two wiring systems or two nerve systems. And the one goes through the vagal nerve or the vagus nerve, which you might have heard of. And that definitely wires the esophagus, the stomach, and most of the small intestine. And then that vagus system, that one's more involved with the day-to-day signaling of food, telling the brain that, yes, there's a meal here, we're hungry, we're full, those sort of things. And usually that system doesn't get a lot of conscious attention. For example, after you eat a meal, you might feel pleasantly full. You might not feel anything at all. And that's because that system kind of hums along in the background because it doesn't really need to bring things to your attention. At the same time, there's a second system called the spinal nerves, and that system is more involved with pain. And so most of the time, those spinal nerves aren't doing anything unless you get a big, huge stretch, really constipated, your bowels really stretched, for example, and then those spinal nerves and the pelvic nerves, they send pain signals up through the spinal cord to your brain. So the vagal system is more day-to-day processing, and the spinal system is more involved in pain. And again, this is shown just as a diagram here. It's called the sensory chain because not only there's a couple of different neurons that it goes through on its way up. So there's one set of neurons or nerves that go from the gut to the spinal cord, and then there's another set of nerves that connect to that in the spinal cord and go up to the brain. By all means, don't even look at those words of all the different all the different anatomy. Memorizing neuroanatomy is the bane of the existence of a medical student. It's hard to remember all that stuff, and for this talk, it really doesn't matter at all. But once those nerves get up into the brain, they splay off into different parts of the brain, which are important in processing meals, but also sensing things, and in certain cases also involved with more conscious sensation where you actually feel it. And so those systems are more about the gut telling the brain what's going on. But the reverse is also true. The brain can definitely alter gut function. And so this is a really interesting case from a long time ago of a surgeon named Stuart Wolf. And he had a patient named Tom. And Tom ate something that was really, really hot when he was a kid, so bad that it actually burned his esophagus. And so they didn't have a lot of options surgically to fix that in the 50s. And so what they actually did was they just made a hole in his stomach wall, and you could see his stomach through his abdomen. And so what he would do is he would chew up his food in his mouth and then spit it out into a bowl, and with a little funnel, he would actually put the food into his stomach. And as you can see, he lived to a ripe old age. But he never swallowed anything really again. But very interestingly, Stuart Wolf did find that he took notes on Tom over the years. And he did say that the appearance of the lining of Tom's stomach, the mucosa, which you can see in this diagram, is the red, the dark red. It would get a lot more red and a lot more sort of swollen when Tom would get angry. And if he was really depressed or bummed out or scared, it would actually kind of get more pale and more white and sticky when he was bummed out. And so there's no question that his emotional state can very clearly affect the status of the stomach. And that was some really interesting data that over time made us realize that there's a two-way connection. So the gut and the brain talk to each other constantly, and they affect each other as well. And we call that a bidirectional communication, meaning it goes up and it comes down. And so they actually did another study. This one was more, I think, from the 80s, where they actually did gastroscopies or put a scope into the stomach of medical students. And they just let it sit there for a little while. And then they told them something really nasty, like, you're a bad doctor or you're going to fail your exams. And when they did that, the feelings of hostility would go up, and they measured the stomach acid secretion went up when they were getting angry. And also, again, that coloration, the stomach got more red. So they definitely have proven this quite scientifically in multiple people. Obviously, I don't think they'd let them do that on medical students anymore, but it is what it is. But the long story short is there's a connection there. Now, there were other times with Tom, the patient, when his stomach lining actually got tender. Most of the time he couldn't feel it, but there was even times when it actually got quite painful. And there were 3 situations when he had a hernia of the stomach where it actually the blood flow got cut off for a time, and we call that ischemia. Another time he had an injury where there was quite a bad scrape on there, and then the third time he had kind of like an infection there, and after that it became quite tender. And so again, that data helped us understand what happens in the situation of chronic gut pain. And so that is one of the main underlying issues with irritable bowel syndrome, or IBS, is that you get symptoms from your gut when you probably shouldn't. So things that didn't used to bother you, you now perceive it as being very uncomfortable or painful. And so this is a situation that we call central sensitization, or a situation where the pain nerves that were previously not activated get activated between the gut and the brain. And so this is a little schematic, and hopefully it's not too complicated to explain this. Okay, so we talked about those receptors, and so in the gut you have a normal stimulus, and I'm not sure if you can see my pointer, but a stimulus, which is, say, a meal. You would eat that meal, and you've got these receptors that just kind of they respond to low stimulus for digesting food, for example. So that's this regulatory activity that goes to that vagal nerve, like we talked about. And so that's just a normal situation. This person has no pain with it because the stimulus is not really that painful. And you can see on the right here, these pain pathways that everybody has are still silent. They're silent because nothing is stimulating them. But when you get a big stimulus, like a painful event, let's say you eat something bad and you get a whole lot of gas and your gut gets really stretched, and that's very painful. What happens is not only do those low threshold receptors for regulatory activity, they get stimulated, but you also activate some of these pain nerves that only get activated when there's a really high stimulus. And that sends signals to your brain saying, "Ow, this is painful." Now, that's what happens with a painful event. But what happens in some situations when you've got a really certain kind of big painful stimulus is it not only activates the sort of short-acting pain receptors, it also activates these silent ones. Okay, so there's ones that often remain switched off most of your life, but these can get turned on. And what happens when these silent pain receptors get turned on is that when you go back to a normal stimulus, those previously silent pain receptors can get triggered even by a normal stimulus. So for example, just by eating a regular or even a small meal, you might get the same pain symptoms as if you had eaten a ginormous feast. And so we call that central sensitization. That's a pain pathway that gets activated after some type of insult or damage. Now, what kind of damage are we talking about? Well, in the case of IBD, inflammation is actually a very common cause. So if you've got a situation where you've got tremendous inflammation in the gut, sometimes that can sensitize those central nerves, the spinal cord nerves. And even once that inflammation goes away after you've been on treatment, you can often be left with chronic sensitivity, and that's one way. Other methods that this can happen are with infections. And so, for example, post-infectious IBS is very common. So you get dysentery or you get, giardia, and even though that germ is long gone, you're often left with symptoms of pain and an upset stomach, upset gut for months or even years afterwards. And other things can cause it as well. And so, unfortunately, what often happens is that even though the insult to your gut is healed, that central sensitization in your central nervous system persists because those silent pain nerves have been activated. And so we can show this very nicely with IBS patients, where they can put a balloon in the rectum. They call it a barostat, really fun test. They don't do it clinically, it's just a research thing. I'm sure you'll be glad to hear. But the idea is that when they put these balloons and they blow it up to a certain amount in the rectum, most people without IBS, they'll feel pain eventually, but not until it's quite filled up quite large. But IBS patients actually feel that well before the normal patients do it. It hurts more at a smaller volume as well. So this concept can be shown quite nicely as visceral hypersensitivity, which is just to say that your guts are sensitive or hypersensitive. And then my final slide is that what happens when those pain signals get up into the brain? There's definitely the way that people perceive pain or cope with pain, or the way they integrate these types of signals into their consciousness can definitely vary. So the same idea, when you put a balloon into the rectum of people with IBS and you have them in an MRI scanner and you measure what's going on in their brain, you can see that different parts of the brain light up in IBS, which are in the bottom there on C and D, compared to the people without IBS, or the controls in the study, which are in A and B at the top. So the location is not that important, or what those sites do. Just look, you can just see that the blobs, the yellow blobs, are a little bit different. But what it means is that the pain processing in your brain might also be different. And so if you perceive things a little bit differently, often that you may perceive it as pain compared to the controls if you have IBS. So finally, we're left, at least in IBS, with something called the biopsychosocial model. And what that is, this is just a way of explaining why people have IBS or one of these visceral hypersensitive disorders. And the three big components are that when you get irritation of the nerves of the gut, you get an altered sensation, okay? And that manifests as pain in most people. You also, when you get that nerve irritability, you can get altered motility of the gut. And so, and that's why in IBS, people always have a change in their bowel habits with the pain, and whether that's diarrhea or constipation, it doesn't matter. Often patients with IBD, sometimes they're more likely to have diarrhea in addition to the pain if they have this central sensitization. And then finally, the psychosocial factors. So if you have anxiety or depression or coping methods that might be catastrophizing, for example, where you're worried that pain means that you're dying or there's something dreadfully wrong with you. If you have aspects or traits of those issues, then often the symptoms are worse. And so that's how we those three pillars are what we use to try and help people with IBS, and also how we try to direct treatments for it. And so finally, in terms of the medical aspect, we have drugs that can treat some of these aspects, okay? And so a lot of the drugs for IBS, especially IBS with constipation, are directed right at those sensory neurons, right at the level of the gut. But for people who have more central sensitization, higher up in the nerves that connect to the central nervous system or higher, we often use medications that will reduce the activity of those silent pain nerves. And so almost all of them are based on antidepressant medications or anticonvulsant medications that we use for chronic pain. In any case, I probably will just stop there. I do have a summary slide, but I think at this point it might just make sense to actually, have I lost control here? There we go. So just to review from my part, the information from the gut goes up, especially the painful stuff goes up through the spinal cord and brain through the spinal nerves, and then the general processing or the regulatory activity goes through the vagus. And the brain, spinal cord, and the gut are all integrated. And so they're connected without a doubt, and they both affect each other. So I think the main thing to understand is that the bidirectional nature of things is important. And often my patients tell me that, I have a lot of pain and it's making me depressed. But very often, if you're depressed, you're going to feel the pain more as well. And so that's often why we use medications to try and interrupt that connection or those communications. Or if you can make one better, you can make the other better. And so the reality is these disorders are very common. And so to carry on, I'm going to hand it off to Dr. Raman.
So I want to thank very much the Canadian Digestive Health Foundation today for inviting me to speak to you on the topic of brain-gut therapies, and also to Dr. Andrews for setting this excellent stage from which I can springboard directly into the rationale for mind-body interactions. So thanks very much, Chris. So I won't replicate this slide too much because Dr. Andrews has nicely touched upon this. But what I will say here is that very much I'd like to highlight this bidirectional communication between the brain, so the central nervous system, and the gut, as well as the gut signaling back to the brain. Now, in addition to what Dr. Andrews has nicely described, I'd like to pay a little bit of extra attention to the external environmental factors, which can really impact the brain function. So when we think of the connectivity between the brain and the gut, things that influence the brain in terms of its size, its shape, its functionality are external items such as stress, the type of stress we experience, the severity of the stress we experience, the strategies or the coping mechanisms we have in place to be able to counteract or respond to stressful activities or stressful events, our mood, our emotions, the way we sleep, the quality of the sleep, all have been demonstrated to impact certain areas of the gut, or of the brain, sorry. So if you remember Dr. Andrews' slide about the MRI that lit up in various areas, there's actually excellent data to suggest that all of these environmental factors do trigger specific areas in the gut. And I'm going to show you or tell you that the brain is a very plastic organ. And what that means is that through interventions that we can apply specifically to reduce stress, improve our mood, alter our sleep function, all of these things can specifically have an impact in the brain that can shrink or grow or alter the function of the brain. So it's a very plastic, changeable type of organ. Now, when not only does the brain signal to the gut, but keep in mind that the gut signals back to the brain. Now, although we're humans and we have billions of human DNA, it's always interesting to remember that in fact there are more bacterial DNA in our bodies. They outnumber us by a factor or ratio of 10 to 1. And there are environmental determinants of the gut bacteria, particularly diet is one of the most important determinants of the gut bacteria. Sorry about that. I'm trying to just get back. And when we think about how the gut bacteria may signal back to the brain, comes some of the interest in evolving data suggesting that diet can in fact have an impact on the brain function. And there are a few different ways this can be achieved, but altering the bacteria in the gut can then translate into altering the molecules that these bacteria can produce. And then through some complex signaling pathways, these gut bacteria then feed back to the brain and can also impact the interpretation of these signals. So I lay that as a background, mainly to then talk about where specific mind-body interventions may come into play. Now, as Dr. Andrews nicely described, the pain experience is really interesting. So sometimes I have patients that have exactly the same type of inflammation in the gut, or even have completely normal guts, but the way they perceive pain can be vastly different. And the interesting question is always why? Why can two people have, two small or large intestines, but have a completely different experience of pain? And I think a lot of that comes to the fact that pain is not a unidimensional experience. There's the way we feel pain, so the sense of pain that Dr. Andrews described. And then there's the entire pain experience. And the pain experience takes into consideration the pain and the stimulus that might be contributing to the pain, but it also takes into consideration the whole emotional context of pain. And if pain results in fear, as many times it does, fear of cancer or fear of some very bad outcome, it can trigger two responses. It can trigger a response of avoidance. I don't want to know about it. I don't want to investigate it. I don't wish to have any further discussion around it. And if that's the route that is chosen, this can lead to significant disability through a few different ways, by catastrophizing or by paying undue or excess importance, or this concept of hypervigilance. And it can also create some inflexible attitudes in the way that we respond to pain. But if that fear and that pain is confronted, and I'm going to talk to you about a few different mechanisms through which this can be achieved, this is often a very successful way to enter the recovery zone or deal with that underlying pain concept. Now, there are several mind-body interventions that have good data in the management of digestive health disorders. And some of these are listed over here on the far left of this slide. So there's moderate to excellent quality data for the role of cognitive behavioral therapy, acceptance and commitment therapy, gut-directed hypnosis, mindfulness-based stress reduction, and biofeedback therapy. And not just in digestive health disorders, but in many chronic diseases. So all of these strategies have been used very successfully in total body pain, so musculoskeletal pain, fibromyalgia, and undoubtedly in the management of irritable bowel syndrome, as well as other GI disorders. And these interventions are effective through a few different mechanisms, but again, underlying or targeting the feelings of catastrophizing or inflexibility and that hypervigilance type of syndrome. Now, specifically within digestive health, cognitive behavioral therapy has been studied fairly well. And CBT is actually very easy to implement and doesn't require a lot of time. It just requires effort and the right professional. And there are many studies in the field around CBT, as we call it for short. And I'm going to just describe this one to you in a little bit of detail. So CBT, it's a practical short form of therapy, and through which one can develop the skills and strategies to change your thoughts, attitudes, and beliefs from emotions that may cause difficulty or are not constructive to a constructive type of environment. And through CBT, one can identify distortions in your thinking process and help you see thoughts as ideas rather than as facts. So I don't have cancer. Maybe if you are having a fixation around or concern around some bad outcome. It helps you identify that although I may feel badly and I think I may have cancer, the objective data don't actually suggest that. It gives you an opportunity to have a 1,000-foot perspective to consider situations from various viewpoints. So in close to 100 people who had IBS, in this study, they were randomized to receive either cognitive behavioral therapy, either delivered by phone or by a web-based intervention, or usual care. The usual care is here depicted on the top dashed line. And then the telephone therapy, cognitive behavioral therapy is in the solid line and the web-based in the smaller dashed line. And in order to be included into this study, people required at least mild to moderate pain, gut pain. And you can see here that after 3, 6, 9, and 12 months, both CBT arms, the telephone-based and the web-based, had significant improvement in terms of pain-based outcomes, and all of IBS, the other symptoms that go into the IBS severity interpretation. So better gut function, diarrhea, constipation, bloating, as well as pain. And this is just one study, but the novelty of this study suggests that this can be done by virtual therapies, including phone-based therapies. Now, the idea of other mind-body interventions also have a reasonably strong and growing database to support its efficacy. And I'd like to specifically talk about yoga as one type of mind-body intervention. Now, when we look at yoga from a historical perspective, we see that it involves multiple different components as highlighted on the left of your screen. But specifically when we talk about therapeutic yoga, or yoga used as a therapy to improve overall health and well-being, most of the studies and practitioners would emphasize exercises, or otherwise known as postures or asanas, specific breath work, otherwise known as pranayamas, and meditation or self-reflection. And when we look at the 5 large randomized control trials that have looked at the effectiveness of yoga-based therapies that include all 3 components, we see that there are excellent results in terms of how symptoms evolve before and after yoga interventions. And there's been some studies also done looking at how yoga can actually achieve these effects. And there are data to show that your stress response as measured by cortisol, these brain neurotransmitters that are released to help facilitate neuronal connections and contribute to the pain experience, these are all significantly modified after a yoga-based intervention. And even very recently in the COVID era, we see that specific yoga, particularly breathing exercises, have a significant role to modulate the immune response. And then overall, these things translate into important clinical symptom outcomes, including the improvement of depression, anxiety, mood, memory, sleep, as well as attention. So these data exist and are also growing. Now, I'd like to share some work that's coming out of our group led by my PhD student, Adriana Da Silva. And she conducted a very interesting study in almost 80 participants that had mild to moderate IBS. And she randomized them into an 8-week yoga program delivered virtually through Microsoft Teams. And people either received the yoga intervention or standard of care therapies. And for the first 4, in order to participate, people needed to attend a weekly virtual class and then do home-based practices. So for week 1, they learned some physical postures, week 2, some breathing exercises, week 3, some sound meditations, and then week 4, they did some breath watching. And then for weeks 5 to 8, after they learned the whole practice, they engaged in a combined practice, both with the instructor online as well as at home. Now, after the 8-week intervention, I'd like to call your attention to some of their findings. Here we saw that in the yoga arm, IBS symptoms improved significantly, as did overall quality of life. We also saw some significant improvements in fatigue, as well as total body pain, stress, as well as COVID-19 stress. In this particular study, we didn't see too much in the way of improvement of depression and anxiety. And we concluded this was the case largely because most people that entered into the study either did not have significant depression or anxiety or only had mild symptoms. Other studies would suggest that improvements in depression and anxiety have been observed time and again. But when I call your attention over to the control arm over here on the right, there were no significant differences after the 8 weeks compared to the baseline results. Now, when you think about your experience with your doctor, particularly your specialist, if you've seen a specialist, you'll recognize that we only have 30 minutes for a new visit in the office. And if you think about how those 30 minutes are spent, usually between 10 to 12 minutes are focused on symptoms, on gathering a history, a family history, a review of your medications, and sort of other things that you might have tried in the home-based setting to understand what's worked and what has not worked. And then the next 5 to 10 minutes may be focused around the investigations needed to diagnose your disease. Have you had endoscopic assessments, colonoscopy, endoscopy, ultrasounds, etc.? And then the last 5 to 10 minutes of the encounter are usually focused on medical treatment options, the variety, the options, the pros, the cons, the side effects, the monitoring. So that leaves us really 0 to 5 minutes in the clinic environment to talk about things that you can do to self-manage your disease. And so you might ask, well, what are these things I can do to feel better? So regardless of whether you have IBS or Crohn's disease or colitis, the data would all suggest that there are things you can do to empower yourself in the home setting. And these include choosing optimal dietary interventions for your condition, managing your weight, either both on the weight management side, as well as being diagnosed with malnutrition or micronutrient deficiencies, undoubtedly can have a role in terms of how well you feel from a GI perspective, but also how well your cognition and your mood and your emotions are managed. You can also engage in therapies to improve your mental health, your fatigue management, sleep and stress improvement by engaging in mind-body interventions and other self-management strategies. So because there is a gap between what we do in the clinical practice environment, in the clinic environment, and we don't always touch upon these self-empowerment tools, our group developed the LifeMD mobile application. And this LifeMD mobile application is a lifestyle and wellness solution for both patients with inflammatory bowel disease as well as irritable bowel syndrome. And the LifeMD approach is one that is very integrative in its approach, and it utilizes diet and provides personalized eating plans to optimize your gut health, regardless of which diagnosis you have. It employs evidence-based yoga, breathing, and mindfulness strategies, specifically to improve pain, stress, sleep, and overall well-being. As described, it includes an evidence-based cognitive behavioral therapy program, which is a self-management program to help improve mental health and change behaviors, as we've discussed. And it also includes a physical activity program to improve strength, heart health, and activities of daily living. And the LifeMD mobile application can be used either self-supported, so you can use it on your own, or it can be used integrated with your healthcare provider or with a health coach. And the health coach option is available together with the application when you choose to download and proceed with the application programs. Now, when you download the app, which you can do from the Apple Store or from the Google Play Store, you will see these screens pop up. You will be asked to declare the health condition you wish to improve. So whether you wish to engage in a program for Crohn's disease, ulcerative colitis, or the Healthy Gut Microbiome program, which is the signature IBS program. There are also a couple of other programs here that may be less relevant for this audience, including fatty liver disease and inflammatory arthritis. You'll be asked to complete a variety of validated questionnaires, so particularly diet questionnaires, depression, anxiety, physical activity, sleep, and fatigue questionnaires. And then after you complete these questionnaires, you will receive a dashboard like you see on the far right that outlines for you your various scores on all of these domains. Now you can review these scores either on your own or together with the health coach, and they can help you identify. So the coach can help you identify the best programs for you in order to improve in terms of where to start, where to focus, and how to advance through the LifeMD lifestyle interventions. Now, although we did not talk too much about diet today, because that's a conversation in and of itself, here's an example of what may happen if you choose to work on the diet program. You will complete a diet questionnaire, and then based on how you respond to these questionnaires and the type of disease condition you're working on, the application will provide for you your top food goals or food strategies to help get you feeling better and improve the course of your gut health. For example, one particular piece of advice that may be provided is around eating 1 to 2 cups of dark green leafy vegetables per day, as highlighted on the screen on your left. Here, you will receive education about why this type of strategy may be helpful. If you have Crohn's disease, this has been demonstrated to improve calprotectin levels or markers of inflammation in the gut, for example. If you have nutrient deficiencies, this can also be helpful to counteract some of those deficiencies. So that type of information is provided with each recommendation. You have the opportunity to track all of your dietary behaviors or dietary practices in the course of the application. And this is also supported by between 100 and 150 recipes specifically to help you achieve these goals, as well as a variety of meal plans to make things simpler. In addition, the yoga, breathing, and mindfulness programs have been specifically developed to help manage your sleep, your stress, and your overall well-being. They are delivered through video-based programs, audios, as well as still shots, and they can be personalized to you. So if you only have 5 or 10 minutes in the morning while you're getting your kids to school, you can engage in a 5-minute breathing program to help improve and reduce that stressful response or that anxiety response when you have many things going on at once. If you have a full hour before bedtime and you're working on a nighttime routine, there's a full-time hour-long nighttime meditation similar to a gut hypnosis program that you can access depending on what your needs for using the application are. And then finally, physical activity is an important determinant of mental health, of mood, and overall wellness. And the physical activity programs are available in the application as well. And they have been delivered or designed specifically by professionals in the field. And they have varying degrees of difficulty. So there is an introductory program for an individual with no prior exercise experience, and a more moderate to advanced program for those that do have that experience. And these programs are specifically designed in mind for people that have chronic diseases. Here, there's an opportunity for you to track your exercise patterns and your interventions as you engage with the application, and you get a chance to monitor how these scores change and how you feel over time. Now, this application is available to any individual with IBS or IBD in Canada, free of cost. And for further information, you can contact the Canadian Digestive Health Foundation, or you can email me directly. So I'd like to conclude by stating that the brain-gut connection is an important component to address in the optimal management of digestive disorders. Time is limited, either in the specialist's office or in the family physician's office, really to have comprehensive discussions. So this particular tool, and there are others as well, digital tools in general are effective to improve symptoms, quality of life, mood, anxiety, and stress. And these tools can be implemented to improve symptoms and wellness in between clinic visits with your doctors and with your other healthcare providers. So with that, I'd like to thank you very much for attending and listening into this session today on mind-body interactions for digestive health disorders, and thank Dr. Andrews as well as the CDHF for having us speak to you today.
Perfect. Thank you so much for that very informative presentation. I'm going to go ahead and take some questions that we had come up. So we'll start with someone in the chat. Yes, this recording will be available afterwards. The name of the app was LifeMD, LYFEMD, to write that down. One question came through from Julie. Do you think those yoga exercises would be good with LAR symptoms patients, LAR? Dr. Raman, that would be one for you. Oh, you're just on mute.
Sorry about that. Okay, so for LAR, I might need assistance with the expansion for that. So
I think it's low anterior resection, I'm guessing. So somebody who's had like a proctectomy or sigmoidectomy for presumably IBD.
okay. Yeah, thanks, Chris. Yeah, I'm happy to start, and then if you want to pop in as well with your thoughts after. Yeah, so I mean, lower anterior resection, that may be a little bit of a different situation in that this is more sort of post-operative neuropathic type of discomfort. So yeah, I mean, I think really any kind of mind-body intervention to help improve that pain experience, I think can only be supportive. Will it be sufficient as a monotherapy to modulate that type of neuropathic pain? I don't know. I don't know if we have enough data around that for me to confidently be able to respond to that. I kind of think we probably need more of a comprehensive solution rather than one single approach. In fact, even medical therapies are probably not going to be entirely effective on their own. So my response there is probably we need a couple of different options that target different mechanisms of that pain pathway. But Chris, I'd be curious to hear your thoughts.
No, I agree with you 100%. I mean, like you said, Maitreyi, there's no downside in doing yoga. Like I was talking about, you know, the vagal and the spinal system, those are also the components of what we call the parasympathetic and the sympathetic nervous system. And the sympathetic system is involved with fight or flight, and the parasympathetic is more involved with digestion and relaxation. And there's no question that yoga can really shift a lot of the functioning to the more the parasympathetic side. And in the gut, you know, that might be positive if the patient's experiencing things like irritability or you know, diarrhea and that sort of thing. But you're right, there's no evidence specifically looking at that connection, but since there's no downside and no risk to the yoga, that I mean, it's it could be a component of the treatment for that, but it wouldn't be the only one.
Okay, yeah, that's great. Okay, another question that came through, and this might be one for Dr. Andrews, is there any evidence-based support to the Wim Hof method, so the deep breathing, ice baths, cold showers, and CRP or the fecal calprotectin levels in IBD?
I don't know the answer to that.
Right.
I'm afraid.
Okay.
Probably something you could Google, but Maitreyi, do you have any ideas? I'm sorry.
I can address the last part of that question around the role of yoga-based interventions and relationship to IBD, but I can't address the first part of that question around the ice baths. So there have been only 2 randomized controlled studies in Crohn's disease and ulcerative colitis looking at yoga interventions. There have been a few other studies that have been done in patients with IBD, but not but their inflammatory markers were not studied. So in these 2 studies that did study inflammatory outcomes, there were significant improvements in CRP, which is a systemic marker of inflammation, And there was also a response, but not complete remission in terms of the calprotectin, which is the gut marker of inflammation. But uniformly, participants with Crohn's disease and ulcerative colitis had significantly a better pain control. So their abdominal symptoms improved significantly. So if you're a patient with IBD, so Crohn's or colitis, you can have both, right? You can have both active IBD, and then you can have IBS overlap. And a lot of people do, up to 30 or even 35, 40% of patients suffer from both. So, and it's always a very interesting question. Can yoga interventions treat inflammation, or is it mainly treating IBS symptoms? And likely there's a component of both. But I think with the quality and level of evidence we have so far, more work is undoubtedly needed to better be able to answer that question around inflammatory outcomes. And I think as we see that our repertoire of biomarkers of inflammation are growing, I think we should see more studies in the field emerge.
Okay, great. Okay. Another question from Chris. Is there enough evidence to support digestive hypnotherapy like Nerva? Either one of you have an answer to that one?
That would be you, Maitreyi.
Okay, I can take that one. So the gut hypnosis is definitely an area that's evolving. And Nerva, I am familiar with the Nerva program. Now, Nerva specifically has not been studied. So there aren't any RCTs or high quality studies looking at Nerva on its own, but there are a few studies that have looked specifically at gut hypnosis with really good outcomes. So in fact, the gut hypnosis has made its way, just like cognitive behavioral therapy, into the IBS guidelines. So when we look at the guidelines that guide practitioners in terms of how we talk about and recommend therapies for IBS patients, gut hypnosis is up there together with CBT. So I would say that absolutely, it is something that you could consider. I think right now we just don't have great data to know which patient is likely to benefit from which therapy. So there are lots of mind-body interventions, as I've shown you. There's CBT, there's gut hypnosis, there's mindfulness-based stress reductions, etc. So I think future work really needs to center in and around which of these therapies is right for you. So we would call that personalized medicine, for example. But until the time that we can map the right therapy to the right patient, I think you have options, and gut hypnosis is one option you could consider.
Great. Okay, great. And would you say that all of these strategies would work for diverticulosis?
Do you want to take that one, Chris?
Yeah, well, sure. I'm just looking at Lisa's questions here, about, so diverticulitis is inflammation of the diverticuli. Diverticuli are little pockets that people can get in the wall of the bowel, very common, especially as we get older. But what can happen is they can get infected or inflamed. And so that can often, even after that inflammation is settled down, that is definitely one of the ways that people can get central sensitization. And so that's actually well described. It's like a post-diverticulitis IBS-like picture. And so the problem with things like diverticulitis, and especially actually IBD, is that doctors are often very worried, and so are patients, that it's not actually just the sensitivity problem, that it's actually a flare of their IBD or another bout of diverticulitis. And unfortunately, that leads to a whole lot of testing and rechecking, and it's a difficult situation when you have those disorders. In IBS, we're a little bit more okay with not checking over and over again, because we're very confident that there's nothing else going on. But diverticulosis, often the treatments that we sometimes use for IBS are sometimes used in diverticulosis or post-diverticulitis symptoms. About 50% of people over 60 will have some diverticulosis, and just having the diverticuli doesn't cause any symptoms. I think there was also a comment from Lisa there that, you don't have to be, the main treatment for diverticulitis after it's settled is just to maintain a really high fiber diet. And I'd also like to point out that the whole idea about avoiding nuts and seeds and all that business is actually been proven not to be true. You should eat whatever you want with diverticulitis, as long as you maintain a high fiber diet with a lot of roughage, okay? Because you want to keep that fiber high. But I think that's probably all I would say about diverticulitis.
Okay, great. And just to go back to the previous question, Dr. Raman, what was the name of the gut hypnosis program that had been studied?
I would have to go back to the literature to be able to specifically let you know about that, but
Okay.
that was not app-based. That was delivered in the context of a research study.
Okay, great. Yeah, we can always follow up with that. Another question, we have about 5 minutes here. Is there any differentiation on how, if to implement the discussed therapies on the different forms of IBS? So are some therapies more effective than others for, say, IBS-C versus IBS-D?
Yeah, for sure. So I think, in your clinical interaction with your physician, typically we would determine, what subtype of IBS you're likely to have. And then the treatments would be targeted accordingly. So if you have constipation predominant IBS, then usually the focus of usual medical therapies would be around improving fiber optimization, fluids, laxatives, and then we have some newer agents available as well to help with the intestinal transit. But with diarrhea predominant IBS, we may choose to prioritize other therapeutic strategies first. I mean, fiber is an odd one because that works for both constipation as well as diarrhea. And then, there's thoughts to be slightly different pathogenesis or pathophysiology for diarrhea predominance. So we may think about dietary interventions. Low FODMAP diets is often effective, and then some antibiotic therapies as well, such as rifaximin. And then there's also some newer agents there. So the conversation in terms of our starting point is usually based on which subtype we're dealing with. But I think in order to have most optimal IBS outcomes, we need a symptom-based approach like what I'm describing, as well as a mind-gut body approach in order to improve and optimize outcomes, because all of these, regardless of your subtype, abdominal discomfort is a common finding. So I think that thinking about marrying mind-body interventions together with usual therapies, but sequenced in a way that makes sense based on your subtype, is usually the way this would be approached in clinical practice. Chris, do you have any thoughts there?
No, I think that was a perfect summary. That was great.
Perfect. So I'll just get to one last question, and then any other questions that we didn't get to, we can always discuss with the doctors afterwards and have it available for you with the recording. So just for the last question, based on both of your experiences, what proportion of the time do you see visceral hypersensitivity being the cause of bloating and abdominal distension compared to gas in patients with post-infectious IBS or IBS in general?
So I can answer that one. The concept that's actually post-infectious IBS is probably the best understood cause of IBS, and especially they've seen it on large scale outbreaks of food poisoning, for example. And so the visceral hypersensitivity, for many people, or for most gastroenterologists, is probably the underpinning concept that we use to build treatments on. And so, often the bloating, it's not usually so much that you make too much gas in IBS, or that you're making more gas. The idea is that actually the gas you make, you actually perceive it, because it does stretch the bowel a little bit. You perceive it as being uncomfortable more. And the idea that I tell my patients is kind of like if you get a sunburn and you get in the shower and the water is cool, but it feels like it's burning. That's the concept that's going on in your gut, essentially, after you've had an infection. And so most of the time, a lot of our treatments are focused on reducing that sensitivity. Now, there's also a question about, whether small intestinal bacterial overgrowth or SIBO is a concept that often comes into play here. And that's a bit more controversial as to know what's IBS and what's SIBO. And, that's actually the subject of a different talk altogether, because we can really chat about that for a lot. But I think to answer your question, Denny, I think a lot of times it is that visceral hypersensitivity, because it's not the germ that's still present, and it's not usually the insult, which is long gone.
Perfect. Dr. Raman, did you have anything, last words to add?
Nope, that was great. Thank you.
Great. All right, well, we are at 8 p.m. So thank you everyone for joining tonight. And thank you to Dr. Raman and Dr. Andrews again for taking the time to present. Stay tuned for the recording, as well as any of the answers to the questions that we didn't get to. And be sure to check out CDHF.ca for any upcoming webinars as well with these doctors. And that's all for tonight. So thank you so much.
Thanks for having me.
Thank you.
Thank you. Have a good night.
Good night, everybody.